Hi, this is Terry Kuti with Deep Sea Foundation. I would like to welcome you to a fascinating conversation that I'm going to have today. And I'm speaking to two highly skilled board certified microsurgeons with numerous accolades, credentials, published materials, and awards. So we're going to go ahead and get going for the sake of our conversation today and what we will be focusing on. I'd like to first of all introduce Dr. Jessie Selber, who is physician executive and the surgery service line chief of Beaumont, where he also serves as professor of plastic surgery. And Dr. Selber, I wanted to ask you and clarify, Beaumont is now under the name of Cornwell Health, is that correct?
Orwell, no end.
Corewell Health. Thank you. All right. Thanks for that clarification.
Like being well at the core.
Oh, okay. Okay. I'm going to remember that.
Like that.
Excellent. Corewell Health. Secondly, and certainly in no order of importance, I'd like to introduce Dr. Neil Tanna. Dr. Tanna currently serves as Vice President of Women's Surgical Services at Northwell Health in Long Island, New York. Both gentlemen will be presenting and discussing the robotic assisted deep flap breast reconstruction procedure. They are well known for both in the US and internationally. Their accomplishments are many, and I believe you will come to understand that in today's video. Please check out the credentials at the end of the video to find out where you can reach out to both surgeons. Dr. Tanna and I recently met in September of 2023 at the London Breast Meeting, where we had a lovely conversation and collaboratively decided that this would be a good video to do. So without further ado, Dr. Selber, I know you have some slides to share with us today. And if you'd like to add anything else before we begin, feel free to, and then we'll let Dr. Tanna roll.
Sure, thanks. Can you hear me all right?
Absolutely. Sound great.
All right. Well, I have been at MD Anderson for 15 years. That's where I spent the vast majority of my career. I got a master's of public health in leadership from Harvard, and then another master of healthcare management at Harvard to do kind of health systems related stuff. So I moved to Detroit and took over surgical services for the Corewell system, where I've got 11 surgical services and 8 hospitals, but my love is still clinical innovation, and I've been driving clinical innovation in robotic plastic surgery since 2005, and it's really been the baby of my career, both my academic career and also my overall happiness. And I'd like to kind of tell you a little bit about why I came upon this most recent application of robotic assisted breast reconstruction and what advantages it has for women. And I'll do that in the form of a few slides, if it's all the same to all of you.
Yes, that would be excellent.
So if you can see some of my slides here, you should be looking at a part of a woman's torso, and the goal of breast reconstruction is and has always been to restore a sense of wholeness and well-being after breast cancer. And that's very important because that suggests that this is an elective operation, which it is. After breast cancer, you don't need to do this, but many women want to because it really does restore a sense of wholeness for them. The problem is the autologous version of this operation comes at a significant cost, and the cost is in the form of abdominal wall morbidity, and you're going to see that as I show a couple of pictures. And the cost is not insignificant. It's a cost that is pretty common, and when you get it, it's very hard to fix, can last for life. And as we physicians enter into elective surgery, first do no harm, or in Latin, primum non nocere, it should be at the top of our minds. We don't want to trade one set of problems for another set of problems, and that's the perspective at which I come at this. So what is the abdominal wall morbidity that comes with this problem? Well, a lot of it is talked about in the form of a bulge, and the bulge occurs because you're opening up the anterior sheath and dividing the muscles where the blood vessels come through and perfuse the skin that we then use for the breast reconstruction. So in order to take that complex of tissue up and apply it to the chest, you have to do quite a bit of exploratory work in the abdomen, and that work will often damage the muscle pretty reliably. And the extent to which it damages the muscle is the extent to which you have to be invasive to get those blood vessels out. Some people who are very good at this say in retrospective series, the magnitude of this problem is about 11%. I would say that, and these authors would even admit that at 11% in a retrospective series is probably pretty low. And we think this is probably more in the 20%. 20% for an elective operation, 20% morbidity is a high rate. I would have trouble accepting that if I was the patient. I think we all struggle with that as providers. Now, the history of abdominal-based autologous breast reconstruction recognizes this tension and has been characterized by becoming less and less and less invasive. So we started with the pet tram, very invasive, the free tram, a little more reliable, similarly invasive, the muscle-sparing free tram, trying to reduce the amount of muscle damage we're doing, and then ultimately the DIEP, which is the enduring state of the art, has been for 25 years, and it changes the dynamic some, but it doesn't really get us all the way there to avoiding these complications. It gets us to where you saw a couple of slides back, our rates around 15%. And so the question that I've been asking in my mind as a person who's uncomfortable with this level of morbidity is there a better way to do this? This is the standard incision through the muscle and fascia for a DIEP. And DIEP stands for deep inferior epigastric perforator flap. That's what that is meaning. And the inferior epigastric part of that is the vessels that go through this muscle. Well, to get those vessels out, you need to make a hole in the muscle, and the muscle ends up looking like this. You've got these intestines pushing up at you. The muscles become devascularized and deinnervated because the nerves get cut as they go across. And this doesn't really go back to normal. We started thinking about whether there was a real difference between muscle-sparing free trams and DIEPs as we were doing them, and did some studies, and it turned out there wasn't a big difference. And you can probably see why based on the schematic. We want to get these perforators, which are right at the level of the fascia, but they come up, they come all the way up from below the muscle. And this pedicle is the one we want to bring up to connect to the blood vessels in the chest. And so you have to go through the muscle in between to connect these two, if that makes sense.
Dr. Selb, if you could go back to that last slide, I do have a question because I think patients might ask, you're talking about the fascial portion. Can you
Yes.
Yeah.
This is of critical importance because the skin incisions all look the same. The skin is an abdominoplasty incision. And a lot of breast surgeons will incorrectly, or for the purposes of advertisement, direct you to getting an abdominoplasty and a breast reconstruction as kind of a 2-for-1. I want to emphasize very strongly here and now, this is not what that is. And there is no operation, and there is no operation for which that clinical scenario will arise for you. This is a hernia, an iatrogenic hernia, that we then fix, and we take the tissue that we remove and use it as a breast reconstruction. That hernia, natural history of that hernia is still going to go on and follow its natural course. And so this is not a mommy makeover in the sense that a tummy tuck in a breast dog is after you've nursed and gotten a few pounds extra around the belly. Different deal, different level of invasiveness, different risks. So really important distinction. Thanks for raising. If you take a belly apart like this, it's not going to go back together like normal. I think as surgeons, we all know that the patients may not be getting quite that view of it. This is the yield of the robotic DIEP, where we take all of the length of the pedicle out, and we really have none of the morbidity that comes from dissecting the muscle. This is an operation I developed in 2019. And have really been popularizing it since, and socializing it with people like Dr. Tana, who have adopted it and brought it into their practice. And now we have a really kind of critical mass around where we have probably, in my mind, the 4 best breast reconstruction academic programs in the nation doing this work. We've got MD Anderson doing it, we've got Memorial Sloan doing it, we got Northwell doing it. We've got the Mayo doing it. We've got the Cleveland Clinic doing it. So we've clearly hit on something correct. And I'll skip through some videos, but only show you that we're bringing the entire pedicle out this extremely small aperture instead of that big shark bite that you were looking at before. And that makes a big difference for patient recovery, ability to do yoga, Pilates, and just activities of daily living. And I'll just buzz through some of this because there's a bunch of technical stuff you don't need to know. But if we go down to kind of the bottom line here, what would you rather as a patient if you had a choice? Would you rather get something, the yellow dots represent the donor sites at the fascial level. Would you rather get this kind of axe wound or something that's very similar to a laparotomy? Or would you rather get, the little port site that we see on the right side of the screen, which is really going to lend no morbidity to your recovery? And from my perspective, as a person who walked into a doctor's office and they said, well, you could either get this or this, but we're not sure which we're going to give you. To me, that's not enough control on the patient's side for me to get this operation. I would simply say, thank you, but no thank you. I'm doing implants. But if you told me I could get you the image on the right, then I would do it in a second. And I think that's the difference between what Neil and I are doing now and are able to promise the patient and what we were doing even 10 years ago, where this wasn't an option.
We will probably get questions on the YouTube channel afterwards, Dr. Selber. So one thing I want to point out to patients that Dr. Tana and I talked about before, as patients, when we get out of surgery, we often think about the aesthetics of this surgery. How are we going to look to ourselves, to our partners in front of the mirror? What is it going to look like aesthetically when we see ourselves? However, going to conferences, talking to all of you, I know full well, and I always say it's what goes on under the hood that really is key to lifelong, long-term goals for patients, what their activity level is, what their lifestyle is. And so under the hood, as you said, you showed a picture earlier, there's an incision like this. With the robotic DIEP, you've got an incision like this. So you have to think really theoretically how much easier that is going to be for recovery. And the other thing that I do want to have Dr. Tana touch on also is that I think that sometimes patients think of robotic, when they think robotic DIEP, they think of a robotic hysterectomy where it's all going to be done through those I'm going to call them trocars. I don't know if I'm using the right term, but they think it's all going to be done, with tiny incisions. But you still have the hip to hip scar. Again, it's what goes on under the hood, what happens with those fascial incisions that you were talking about. So that's just my 2 cents as a patient. And Dr. Tana, I'll let you two take over.
So, yeah, thanks, Terry. I think for Jesse and I, it's really nice to be here and be involved. Before I sort of get into this, I want to give the viewers my perspective. I'm a breast reconstructive surgeon in New York, and I'm fortunate to be surrounded by some very, very good surgeons, and that just has elevated the game that we all are in. And so I pride myself on offering every form of breast reconstruction and having good outcomes. And I want to sort of give the viewer from that vantage point that they listen to this conversation, because outcomes are beyond the short term, right? You have to think long term. And that's what this discussion is going to be about, is what are these long-term outcomes? Because if you care about your patients like we do, and you see them long enough, you start seeing things that you don't like, and they're unintended consequences. And for the viewers, don't think just short term, think long term. So here I am, thinking I'm the greatest surgeon in the world, sitting here listening 2017, circa 2018. And I listen to Jesse Selber and I say, this guy's crazy. It's gimmick, it's marketing, it's stupid, right? And then literally in parallel, you start following your patients, you start listening to what's going on, and you start seeing some unintended consequences of this DIEP flap, which is an amazing operation. It is probably one of the greatest operations in plastic surgery. And when you compare it to the traditional tram flaps where they took the entire rectus abdominis muscle, it's a huge advancement. But what you realize is there's still some significant abdominal wall morbidity. So start paying attention to some of Dr. Selber's work and what he's talking about. And I become a believer, and it's not for every patient, and there are some limitations in its current form, and it does increase the length of surgery, even if it's by 5 minutes, which it's more than that, at least in our hands, it does increase. And there's some serious limitations to the technology in its current form, but it's coming. I think the changes are coming to allow that. And so I start paying attention to his techniques. And for the viewers out there, I basically invite Dr. Stalber to come from Texas. He was at MD Anderson at the time, and he basically taught us how to do the surgery, and we learned from him. And having seen these, we've done about 22 or 23 of them now, and we've got a bunch more scheduled, and we're limited actually by the institution on how many, just by the availability of the robot. And so in the right candidate, it's an incredible operation. And, there's the Latin phrase, speaks for itself. That's really what it is. When you look at these photographs and you look at what he showed, like that opening to the fascia. When we talk about the word fascia, we're talking about the lining of that six-pack muscle. And when you look at it, what he showed in the traditional DIEP flap, that opening is unzipped the length of the entire vascular pedicle, the blood vessel. So you have to unzip that fascia. And when you do it robotic in the right candidate, you unzip it for a fraction of that, maybe 20% of that at most. So you have a 12 to 15 centimeter that's traditional, and you have a 2 to 3 centimeter in the robotic. Mm-hmm. So that photograph just speaks for itself, because think about what that's going to do long term for that woman. Yeah. And I think it's really important that the woman out there that's listening to this, like anything, just take it from the more global stances. Like, what we can't stand is someone saying to a woman, oh, that's a stupid operation, right? That's like telling a woman breast reconstruction is a stupid operation, right? Take it back 20 years ago, 30 years ago. That's a woman saying, oh, no, you're too old, or you're not the right body type, or you're not, these are all subconscious bias against this operation. And that's, if there's, to the woman that's out there, I was that person, right? I totally was against this, and I've literally, become in the Selber camp. And what's interesting is that, all of a sudden, and Dr. Selber sees it, now there's surgeons all across the country who are reaching out, who want to do this because they're seeing it. They're seeing what's going on. So I think, for patients out there, don't let someone say to you that, they're not a candidate. So that's my perspective. And for the discussion that, follows, I think just to give the viewer, I was a critic. So it's not that I just, blindly follow here. So I think with that said, I do have a few points, and I'm going to, like I said, my technique is really Dr. Selber's technique. I learned from him, and I still turn to him, every once in a while. So I think a few points, and I'll let him comment. I'm going to go one by one here. Is, I think, again, people look at robotics benefits in the short term, pain reduction and things like that. Putting that aside, because that's short term, right? Everyone can get over pain. But there is definitely, I want to ask him to sort of explain to the viewers, what are the benefits long term? And, when we talk about preventing abdominal wall morbidity, or improving abdominal wall function, or avoiding abdominal wall complications, I'd like to ask him to sort of phrase to the viewers out there, what are these complications or things that we see long term that we're trying to avoid with the robotic technique?
Yeah, I would like nothing more. So I'm going to resist the urge to actually take my top off and show what the anatomy is on my body. But if you just picture somebody who's got 2 rows of 6-packs down the front of their torso, from their ribs to their pubis, and these are people, who presumably are using those muscles for something, because they're fairly well developed. And even if they're not developed in that way, for the young woman, or even the middle-aged active woman who goes to the gym, does yoga, does Pilates, runs, does all these things, and takes some pride in both the form and function of her core. What we're doing, if we're not doing a robotic version of this operation, is we're basically splitting one of the rectus muscles in half, all the way from about the umbilicus to close to the pubis. And that's a pretty big stretch of road. Now, what are the consequences of that? Can't we just sew it back together and we'll be cool in the gang? No, we can't, because what happens is we divide the nerves that cause that muscle to live. And so that muscle over time, even if it looks perfectly happy when we put it back together, because of the nourishment that nerves give muscles, the muscles become atrophic. And if you look at them, if you look at a bulge that you're trying to repair, so one of these patients who's had that, and you look at it from the inside, what you see is this pale, spindly, spread out muscle that appears to have been de-innervated. And that muscle is useless in doing anything from a core related, power related, but not only that, it can't even keep your abdominal contents really well in your body. So that over time, that's what's preventing your kind of lower gut from stretching you out. And we all see older people walking around with these pot bellies, and some of them have, and a lot of the time it's not fat on the outside. It's just their abdominal wall has become atrophic and expands with the intra-abdominal pressure. And if you don't have muscle to oppose that, you're going to expand out like a balloon over time. And that's what we see. And particularly
you're talking about motor nerves that are
motor
feeding.
nerves that nourish and cause function for that muscle that we've divided. And so if you do that work, you're going to get this. And as Neil's just aptly describing, the long term, you know, we don't usually look at hernia outcomes in less than 3 to 5 years. So if we're talking 3 to 5 years out, most patients are going to see this problem, and they're going to come back and they're going to get plications, and all that stuff's not going to matter really, because there's no muscle there. So it's going to stretch out again, and you're going to be right back where you started. All of this can be prevented if the operation is done in a minimally invasive way. And that's what I want to drive home. And, you know, to Neil's point, like he wasn't a believer and then he was. Well, I'll tell the funny anecdote that he didn't. I mean, the reason why he came to, you know, had a kind of a come to Jesus with this is he had some patient like stalking him saying, I'm in New York City of all places. Why can't I get this operation? Am I going to have to call Selber and get him on it? So finally he was like, all right. I'll investigate this. I'll look into it. And I think as he looked into it, he kind of, you know, saw, well, maybe there's something here. And now I'm curious to know what his perception is, you know, a couple of years down the road, having done this, like, is he real confident? My sense is he is, you know, and that's been my experience with everybody who adopts this. They're like, I don't know why I was doing this the other way. I just didn't know.
Well, I think, you know, all of us, we develop habits, we develop things that are comfortable within our armamentarium, within our wheelhouse, however you want to frame it. And surgeons are no different. They perfect a skill, and old habits die hard, right? So my message, I guess, my call to action for patients who are listening to this is to ask about this type of surgery, ask about the robotic DIEP. If we do not use the vocabulary and the terms that we're talking about today, then surgeons they need to know that patients are savvy consumers these days. So I see two risk takers really in this whole scenario. One is the patient who's willing to have this surgery, and two is the surgeon. So my call out to surgeons who are listening to this, give it a try. You've got two folks here who are willing to share their knowledge and information on it. But I do have a question for either one or both of you as a patient, because access to care is a very important topic to me. And honestly, this is not accessible to all. How many women do you have that need to travel for this surgery? Because it is really, I believe, and you can correct me if I'm wrong, dependent upon the facility and who has the equipment for the robotic assisted DIEP. Am I correct in that assessment?
Yeah, I mean, I think you are.
Yeah, it's the facility, and it's also the interest of the surgeon, right? So,
Correct.
right, like it was, and after that patient, Selber talked about that really wanted this. I mean, she literally came in with Selber's papers and his thing, not my stalker, more his stalker, but she came in with all the stuff, and then I started paying attention at the same time, like how many of my patients were having this. So, what Dr. Selber just said in terms of this is again independent of any body habitus. Who wants to have a bulge or a hernia? For those people listening, let me just, the fascia surrounding the rectus muscle is basically like spandex. So think of a spandex in your mind. If you cut the entire spandex and then sew it, what's the strength layer of that spandex? Now, I'm not saying, perfection is to not cut the spandex at all. That's essentially like don't have surgery, right? But if you're going to cut the spandex and you just cut a tiny little hole and then you sew that back together. So you cut 10% of it versus 90% of it. Think about the integrity of that spandex. And that spandex is going to allow for prevention of a hernia or a bulge. A bulge is essentially the word for weakness. So he's 100% correct. It speaks for itself, the technique. I think it's important, the next thing I think it's important is who is a candidate for the procedure. And literally I had a patient just today. When you talk about access, we love seeing these patients. And what we love more is, Selber and I laugh about this, is when someone says to a woman, oh, you don't have enough fat for a DIEP flap, or you're too old for a DIEP flap, or you don't need a DIEP flap. Implants are the best. And so it's basically because of access and comfort level of a patient, the surgeon, right? So this is very true, is even at the higher level of DIEP flap, we still have patients who are told no. So that to us is the most annoying thing. But I think what is a reality is not every person in its current form is a current candidate. And so when you look at it, it's all about the vascular anatomy for that blood vessel. And the blood vessels that we need travel, from the fat through the muscle down below the muscle. And the distance at which it travels in that muscle will really determine if someone is a candidate, and really where it dissects down in through under the muscle. And an ethical surgeon is the one that really will look at that MRI or CAT scan with the patient and say that. But beyond that, the vascular anatomy, there's other things that we consider. And I think, it's important for that. So my question to Dr. Selbers, so any viewer out there who's seeing this, who is a good candidate, right? Especially in your practice, since this is your, you are the person who basically invented this technique. So who is a good candidate for robotic DIEP flap?
So anatomically, it's somebody with 1 or 2 closely grouped perforators with a short intramuscular course. That's not going to mean a lot to a patient, and they're not going to know that. So that's information that you get through a CAT scan, and we work patients up routinely with a CT angio or MRA or whatever the technology of choice is. But whatever it is, it allows you to map out that vascular anatomy and then make important preoperative choices about whether or not a patient's going to be a candidate. And I think that selection process is a really critical part of the intellectual exercise to then being able to move to this surgery and saying, you're a candidate, we're moving to this type of surgery. That doesn't mean everybody who comes into your office who wants robotic surgery is going to get it. You can still provide some benefit, even if you're not an ideal candidate, but it gets a little fuzzier along the margins of inclusion criteria. What I would warn against, and to your point about the access and everything else, is if you walk into somebody's office and you bring up robotic DIEP and they say, oh, that's gimmicky, that's stupid. And you say, well, have you ever tried it, or how's it done? And they have no idea how it's done and they've never tried it. I think what you're encountering is, as Nietzsche famously said, if you have a hammer, all the world's a nail. And when you only have your hammer, you're certainly not going to be looking for nuance in how to put the thing together. And so there are lots and lots of surgeons out there who are like that. And I would not let that deter you from getting the outcome that you are looking for, because the future of medicine is personalized medicine. And if you don't want your abdomen ripped apart because somebody doesn't know how to do the operation in a more sophisticated manner, that's your right to then go somewhere else where they can. And
let your feet do the walking.
Yeah, that's
decision making.
That's patient, that's shared decision making, that's
Right.
patient empowerment. And we have enough people now. I'm happy to say that the network of people out there who can do this is wide enough that you don't have to go coast to coast to find somebody who can do this operation. You can call me, you can call Neil, you can say, who am I close to that does this? And we'll, either send you to one of us or send you to one of our 20 colleagues who are now doing this. And utilize your options. There's also, along those lines, I don't want to get too philosophical about things, but Upton Sinclair once said, it's very hard to convince a man of something when his salary depends on his not understanding it. And there are a lot of people who you'll go to and say, but I heard this was the thing, and the person will just kind of blow it off and say, well, that's a silly thing, and that's just all advertising and so forth. And that's somebody who wants your business. That's not somebody who wants to do the right thing for you.
Mm-hmm. Yes, and I'm glad that you emphasize that they can call either one of you to find out if they should go to find out if they're a candidate for this surgery. And I'm just going to name drop a little bit too, Dr. Selber, because I did a YouTube video with someone internationally who said, I talked to Jesse Selber about this. I was influenced across the pond by your work. And it's Dr. Joe Dusseldorp over in Australia.
Sure.
And so now, we can look at these things internationally. But I really wanted to focus today on the 2 U.S. surgeons who really are doing a lot of this work. And of course, Dr. Selber, MD Anderson was my home away from home for my first diagnosis. And so I've been following both of you. So it's been great to have you both on for an interview today about this. And I will look for comments after this is published and put on the Deep Sea Foundation YouTube channel. And I'm going to repurpose it for podcasting too. So we'll just get it out there so that patients can listen. They know what to ask their surgeons. And I'll look for comments. We may have to do a follow-up on this at a further date. But do you have either of you have anything else you want to add before we wrap up here?
Yeah, I'll just say, listen, I think to the viewer out there, again, I think you're going to find a lot more criticism or naysayers. And, when something is popular or rising, there's just equal amount of criticism. And so they should just take that with objectively understand what is being said. And the reality is that for the time being, you have to look at robotic breast reconstruction or robotic surgery and plastic surgery for today at this time in a pyramidal structure, right? So if you need a heart transplant or a lung transplant, your community hospital may not be the place that does it. And on that pyramidal structure, if you look, we're just like when DIEP flap started, it may not have been at every hospital. And now what's great is DIEP flap is at a lot of community hospitals, and it's in far reaches of the country. And for the time being is that we're lucky that it's not just the two of us, because all of these people like me have learned from him, and they're throughout the country. And so one of the things a patient can always do is just, get their mastectomies done at their local hospital with tissue expanders, which is a temporary placer, and travel to one of these 10 to 15, 20 sites that are now doing it. And yeah, it's unfortunate to have to travel, but it is where it is, because on the other hand is that this is a newer technology. And like I said, for me, I'm in my only 20s. I've only done 20, and I'm very honest, and you talk to Selber and he's, double, triple, quadruple that volume. So, we go at our own pace, and we also as surgeons have our own limitations and our learning curve. So we have to respect that as well. I'm definitely, he's more inclusive in his criteria than I am, because he's just done way more than me. So I think that you just have to realize, if you're told no, there are options, and we can work that out with the patient to get them to where they ultimately want to be. So I think explore all the options before you're told no. Don't take no for an answer until you really have talked to the guy who invented the operation. So that's what it comes down to. So I hope all the viewers understand that.
Yeah, I completely agree with that, Neil. And I would say, I find people making short-term solutions, short-term decisions that ultimately impact lifetime solutions. And don't make a decision out of convenience that is going to haunt you for the rest of your life. I don't want to scare anybody. It's, you do whatever you want to do. But the reason why I developed this operation is because I didn't want the operation in its current form. I couldn't live with myself. I mean, I don't want to make it sound, overly dramatic, but I could not live with myself offering this operation that I felt bad about on some very deep level. And if somebody said, what would you recommend to your wife? I would say, I might have a different wife than you are a patient. And that's not an answer that's satisfying to people. I want to be able to say, I would offer this operation to my wife. I would get this operation. This is the best form of this that we have. It's 1,000 times better than what was being offered before. And 5 years ago, I wouldn't have offered this to you. Today, I'm happy to say that I can and I will. And that's where I'm coming from. That's what makes me happy about this. And the more Neils that I can make in the world, and the more people that embrace this, the better off women are going to be in the world. They're going to be happier with their breast reconstruction. They're going to be more functional. They're going to be more active participants in the world around them. And they're going to be more liberated. And hey, who doesn't want more liberated women in our world? That's what it's all about.
That is a good note to end on. I have to tell you, you both fulfilled my goal today as an educator. I always believe it's providing vocabulary, providing the information that patients need to ask during their surgical consult. Also, I think I have come to the realization that having surgeons on this program, I want other surgeons to be listening. So I hope there's two audiences listening and two audiences acting on this interview today. And I do want to thank you both, Dr. Neil Tanna and Dr. Jesse Selber, on the robotic assisted DIEP flap. Gentlemen, thank you both for joining me today.
Thank you.
Thank you very much, Terry. Good to see you, Neil.
Take care, guys.
Good fight.
Have a good one.
All right.
Terry, thanks a lot.
Absolutely.
Thanks for getting the word out. Have a good one.
Thank you.
Mm-hmm.